In this video, we present meniscus reconstruction using autologous tendon combined with opening wedge high tibial osteotomy, a technique to achieve rigid fixation and avoid interference between locking screws and the tibial bone tunnel. This is a 65-year-old woman. She complained of left knee pain without any trauma. Lower long leg radiograph shows that the weight-bearing line was 44%. MRI shows a medial femoral condyle spontaneous insufficiency fracture, meniscal posterior root tears, and bone marrow edema just below the attachment of the medial meniscus posterior root. An approximately 4 to 5 centimeter oblique incision was made, and the gracilis tendon was harvested using a tendon stripper. Next, the medial collateral ligament was completely released. The harvested tendon was trimmed to approximately 3 millimeters width for easy penetration in the meniscus. Krakow sutures were then performed. Knee arthroscopy was performed, and extrusion meniscus and MMPRT were diagnosed. Using a special drill guide, a 2.0 millimeter guide pin was drilled from the medial tibia. Then, a 6 millimeter diameter overdrill was performed through the guide pin to create a bone tunnel. Next, using knee scorpio, a 2.0 fiber wire was passed approximately 1 centimeter proximal to the rupture side of the posterior root medial meniscus. Then, using a suture relay method, Ethibond number 2 was shuttled to 2.0 fiber wire to enlarge the hole in the posterior root medial meniscus. A bone pick was used to enlarge the hole in the meniscus. Next, using the suture relay method, an autologous tendon was passed through the meniscus. Finally, the autologous tendon was shuttled into the tibial bone tunnel previously created. Next, with the knee joint in slight flexion, the autologous tendon was pulled with a force of 20 N using a tensioner. An absorbable interference screw was inserted under fluoroscopy just below the articular surface to fix the autologous tendon. Then, Kirschner wires were inserted in the hinge point under fluoroscopy. A transverse and ascending osteotomy was performed using a reciprocating saw and chisels, leaving the lateral cortex intact as a hinge. After osteotomy, the osteotomy site was opened using an opener and beta TCP spacers were inserted. The spacers were covered with fascia of pes anserinus. The plate was placed approximately 20 millimeters distal to the joint surface under fluoroscopy to avoid collision between the inserted interference screw and locking screws. To avoid damaging the interference screw, only the front bone cortex was drilled and the guide pin was inserted with a hammer. After confirming that there was no interference, the cannulated locking screws were inserted. Finally, we evaluated the reconstructed meniscus and extruded meniscus that was repaired using arthroscopy.